Okay, good morning. Thanks for everybody for being here, and thanks to our sponsors, Amgen and Bristol Myers Squibb. Our first talk this morning is by Dr. Kirsten Shaw, who is one of our star chief residents here at Abbott. She's a native of Cambridge, Minnesota, one of our outreach spots. And about 1 year ago, she made the decision she wants to do cardiology. And since then, she's really turned it on. She's got a number of research projects going. She's the first author of the article on myocarditis from the COVID vaccine with Mario and Joao, which got a lot of press. And she's passionate and enthusiastic about cardiology, and hopefully we'll see more of her in years to come. But this morning, she's going to speak about clinical characteristics and change in clinical outcomes for patients enrolled in a non-academic multidisciplinary cardio-obstetrics program.
All right, take two, better. So I'm going to talk to you about a project based out of our cardio-obstetrics program here at Abbott Northwestern Hospital. And this project was led by Dr. Saxena of cardiology and Dr. Wagner of maternal fetal medicine. And no disclosures. So for some background, maternal mortality rates in the United States have been increasing for the past 2 decades. And while the causes of maternal mortality are quite diverse, cardiovascular disease continues to be the leading cause of death in pregnancy and in the postpartum period. And they found that the majority of these deaths in pregnancy that are due to cardiovascular disease are actually preventable. So in response to the rising rates of maternal morbidity, mortality, and then the associated fetal risk, there's been a recommendation for a woman with cardiovascular disease to be treated in specialized cardio-obstetrics teams. And this is a recommendation that's been gaining traction, particularly in the past couple of years here, with formal statements now from the AHA, the ACC, ACOG, and other societies advocating for this management strategy for these complex patients. And it's notable that most centers that treat heart disease in pregnancy that's both congenital and acquired in nature are based out of academic institutions. But in 2018, we established a non-academic multidisciplinary cardio-obstetrics program here at Abbott Northwestern Hospital. And so this abstract I'm going to present, we describe the demographic and clinical characteristics of the patients enrolled in this non-academic multidisciplinary CV-OB specialty program. Compared to patients who received standard of care prior to this program inception. So some background on the program. The cardio-obstetrics program is comprised of cardiologists and maternal fetal medicine specialists, and they work together to provide evidence-based care to pregnant women with cardiovascular disease or cardiovascular disease symptoms. And all patients have a RN care coordinator. Most visits are conducted with a multidisciplinary team of providers, so cardiologists, perinatologists, and pharmacists. And some of the structured program components that are important to note, there's preconception counseling for these patients who are at increased risk, and then there's risk stratification for every patient, which is incredibly important for identifying who's at increased risk of adverse cardiovascular outcomes and who needs ongoing active surveillance throughout their pregnancy. And then all cases are presented at a multidisciplinary conference prior to delivery for delivery and then also postpartum planning. And so our hypothesis was that women who were seen by this multidisciplinary CV-OB program would have higher cardiovascular disease risk profiles compared to the pre-programmed controls. So to study this, we conducted a retrospective chart review of 113 patients who received their care from the CV-OB program. And then we also looked at 338 pregnant women who were seen by cardiology in the year prior to this multidisciplinary program's inception. And so we gathered data on demographics, their comorbidities, their substance use, their medications that they were on. And then we calculated their cardiovascular disease risk profile using 2 of the established risk models. So the CARPREG-2 risk index, which predicts the likelihood of maternal cardiac complications, and then the MHU classification system, which is a bit more comprehensive and estimates the maternal and fetal risk of cardiovascular adverse events and morbidity and mortality. And so looking at this first table here, this shows those calculated risk indices I just mentioned, the MHU MHU here on top, and then the CARPEG-2 on bottom. And then we have our CVOB group patients in this left-sided column and the comparison group here on the right. And again, the historical comparison group are those patients that were referred to and seen by cardiology in the year prior to the inception of our program. And so the important takeaway from this data set here is that the CVOB group patients had higher cardiovascular disease risk scores. If you take a look at the patients who scored a 2 to 3 or higher on this MHU scale, which correlates with a risk of intermediate to severely increased risk of maternal morbidity and mortality. You can see that it was about 57% of the CVOB group that fell into that score category, compared to only 17% in the comparison group. And then similarly, if you look at a CARPEG-2 score of 2 or higher, which correlates with a similar risk, you can see that we had about 51% in our CVOB group fall into those score categories compared to only 28% in our comparison group. So statistically significant higher risk scores in our group patients. And then looking further at the comorbidities of these patients here, it was notable that the CVOB group had higher rates of cardiac valvular disease. You can see here 27% compared to 8% in the comparison group. There was an interesting trend towards an increased prevalence of hypertension in the CVOB group compared to the comparison group. This was not statistically significant, but with the trend that we were seeing, we do have suspicion for a type 2 error, and that with the larger sample size that may have trended towards statistical significance. And then just notably, renal disease here was the other significant difference in comorbidities in these patients, 4% in the CVOB group affected by renal disease compared to 0.3% in the comparison group. And I just think that highlights the medical complexity of these patients when you're balancing renal disease and heart disease in the setting of a pregnancy. And then looking further, looking at race for these patients, the CVOB group was more racially diverse than the comparison group, with about 34% in the CVOB group being non-white compared to 24% in the comparison group. There was no significant difference between parity or age or Hispanic ethnicity between the two groups. And then finally, looking at medications in these groups, it was interesting that there was no difference in these medication categories prior to pregnancy between these two groups. But during pregnancy, if you looked at the antiplatelet and antihypertensive medication categories, there was quite a significant difference between the two groups, with 27% in the CVOB group on an antiplatelet agent compared to 9% in the comparison group. And then similarly for the antihypertensive therapy, 35% to 18%. And so to summarize these results, there was no difference with regard to parity, age, or Hispanic ethnicity. The CVOB patients were more racially diverse than the comparison group. The CVOB group patients had higher rates of valvular heart disease. They had higher cardiovascular disease risk scores, and then antiplatelet and antihypertensive use were higher during pregnancy in this CVOB group patients. And so concluding remarks on this, just once again, guidelines do recommend this multidisciplinary CVOB management for women with heart disease and pregnancy. And the CVOB group referral was less than half of the prior year's referral to cardiology in pregnancy. And so while these CVOB group patients that we saw were those who were at higher risk with those higher calculated risk scores, utilization of this program could be increased in all risk categories, even those scoring on the lower end of the MHU or CARPEG-2 score, as this multidisciplinary cardio-obstetrics team model may have the potential to improve outcomes for these patients. And then while we're speaking of outcomes, I want to mention our second abstract that will be presented at AHA as well, where we did look at clinical outcomes for patients enrolled in this non-academic multidisciplinary cardio-obstetrics program and compared them to pre-program controls. And so briefly, results from this, we found that women who received their care in the CVOB program had more cardiology tests during pregnancy compared to their pre-program control group, so a median of 8 tests versus 5. They had a half a day longer length of stay on average for vaginal deliveries. And they had more telemetry during pregnancy, and then were more likely to see a perinatologist postpartum. However, the women in the CVOB group were less likely to have inpatient or ED visits in the 6 months postpartum. And this was a striking difference. The comparison group, 71% of those patients were readmitted or had an ED visit in that 6-month postpartum period, compared to only 34% in our CVOB group. So quite a striking difference. And so concluding remarks on this, the CVOB patients were more closely monitored by cardiology during pregnancy and postpartum with more tests. There was more telemetry use, longer lengths of stay. But in this multidisciplinary non-academic CVOB program, coordination of care and monitoring during pregnancy may have contributed to fewer postpartum emergency visits and readmissions. And then just a reminder, both of these abstracts are going to be presented in full at the upcoming AHA conference. So thank you, and happy to take any questions. Yeah.
If the risk profile in the CVOB patients was higher, where were those patients the 2 years preceding with all the valvular disease and whatnot? What do you think? I mean, what do you explain that on?
It's a good question. I don't know, Dr. Saxena, if you want to comment on that at all.
You know, it's a really, really good question. I was kind of surprised to see how much more. I think a lot of it is word of mouth. I don't know that those were necessarily within the system. It's quite surprising as to where the CVOB program draws from as far as Fargo, Essentia, St. Cloud. And so I think as word of mouth has gotten out, all of those individuals with aortic stenosis, a lot with mitral stenosis and the regurgitant lesions came from elsewhere. And so I just don't know if the referral base was there. What isn't presented and is interesting is when we look at the data, there's still a large percentage of individuals that were referred to cardiology, but not referred to CVOB in the 2018, 2019 years as well. So that will be a next set of analysis once we finish the comparator groups. I am curious to see who those people were that were still referred to cardiology, but not seen within CVOB.
Excellent. Thank you.
Great job, Kirsten. And I just would like to make a plea, like, I think this use of the word non-academic is not really accurate. We do 250 papers a year, numerous fellowships, talks. And we always debate this, and I guess my personal bias is non-university. Maybe more appropriate, but we've fought that battle for years with Hennepin is how do we describe our fellowship? Tertiary teaching hospital, teaching research hospital. Anyways, that's just my personal bias. So the next speaker really needs no introduction, but Dr. Bob Hauser, who quote retired in 2015. He's a graduate of the University of Cincinnati College of Medicine. He was a professor at Rush before he left to become the CEO of Cardiac Pacemakers, which is now Boston Scientific. He's a active member of the Heart Rhythm Science Center here at the Minneapolis Heart Institute Foundation. I would also highly recommend his book, Heart Stories, about the history of cardiology, and still very actively involved, sends me references to articles that I haven't seen yet on the aorta and such, but thanks, Bob, for being here and presenting your abstract from upcoming AHA.
Can you hear? Can you hear me okay? So this is actually 50 years ago, I presented my first abstract at the AHA, 1971. So this is somewhat of an anniversary. Okay. Here we go. This is why I feel old. When you can't work. Yeah, sure. Thank you. So I'm talking about adverse events associated with AV node ablation in patients with an implanted leadless pacemaker. No disclosures. So AV node ablation is performed in about 5 to 10% of patients undergoing leadless pacemaker implantation. The term is ablate and pace. Data from the microtranscatheter pacing study, continued access study, post-approval study suggested that patients who are undergoing simultaneous leadless pacemaker implantation and AV node ablation are subject to more adverse events than patients who are not undergoing simultaneous AV node ablation. Also of note is the fact we spent the past year at the Heart Rhythm Science program evaluating leadless pacemakers, and we've been publishing on this in the past 6 months. So those of you who don't know, the leadless pacemaker is implanted via a femoral vein access. And because of that, it's often convenient then to do the AV node ablation because you only need one vascular stick. The ablation catheter is placed across the tricuspid valve. This is the implanted micro pacemaker, which is manufactured by Medtronic. It's a VVI pacemaker, does have some rate adaptive capability. So the ablation electrode is about 30 millimeters away from the pacemaker. And of course, this is going to vary from patient to patient and from implant site. And once that ablation catheter is placed on the His bundle, energy is applied, the His bundle is destroyed. And what's very important to understand is the patient then is asystolic. And so you have to have a pacemaker in place, whether it's a temporary or permanent, that is functioning properly in order to avoid adverse events. Our hypothesis was that the concomitant or staged micro leadless pacemaker implantation and AV node ablation may result in serious adverse events or malfunctions due to increased pacing thresholds, exit block, or interference with the pacemaker's electronics. So we searched the MAUDE database for the search term micro and ablation for adverse events that occurred between 2016 and October of this year. We use special software to do that. We removed duplicate reports. Data were extracted from the various narratives, which is a very laborious process. And we found 28 patients had AV node ablation at the time of microimplant. 15 patients had ablations done with 1 to 2 days after implant. And of those 42 patients, 38 patients suffered 1 or more adverse events. There were 3 deaths, 1 perforation and tamponade, 1 asystole resulting in cardiac arrest and failed resuscitation. And 1 patient died at home 4 days post-op, cause unknown. 24 patients lost pacing or exit block. That resulted in 1 cardiac arrest, 1 prolonged asystole, 1 syncope 2 days post-op. 9 patients had capture restored by simply reprogramming the pacemaker to a higher voltage, and 15 had their micro pacemakers replaced. There were 3 cardiac perforations, all had a pericardiocentesis. There was 1 asystole and cardiac arrest. 2 of those patients had their micro pacemakers replaced. 8 patients developed a high threshold. 3 had their pacemakers reprogrammed to a higher output. 5 had their pacemakers replaced. So altogether, 22 patients had pacemaker replacement, either a transvenous pacemaker or a new micro pacemaker. 4 micros could not be interrogated temporarily. So after this radiofrequency ablation, the memory was scrambled within the pacemaker temporarily. This was due to EMI from the ablation system in at least 1 case, and probably a direct effect in the other cases. 1 of the automatic threshold test features malfunctioned, but there was no permanent micro malfunction or damage identified. And it's important to emphasize that the pacemakers were replaced not because of damage to the pacemakers themselves, but because of injury to the tissue. So in conclusion, AV node ablation during or shortly after leadless pacemaker implantation may cause exit block or high thresholds and result in serious adverse events and need for pacemaker replacement. While ablation may not cause permanent leadless pacemaker damage, it may temporarily interfere with pulse generator communication and diagnostics. Now, the incidence of complications in patients undergoing concomitant or staged leadless pacemaker and AV node ablation is unknown. We suspect that it's low, but we do not have a denominator, which is one of the problems with the FDA database. You don't have the denominator. So studies are needed to determine when and how ablation can be performed safely. And I did want to mention that Chuck Gornick and Joe Ellen Moore were co-authors on a paper, I believe it was published in 2018. The study was based on simultaneous AV node ablation and leadless pacemaker implantation in 2015, 2016, and they had no adverse events in their series. They had no adverse events. There was also another study using a different leadless pacemaker, the NanoStem, which is owned by Abbott. And they actually did AV node ablation 2 weeks after the leadless pacemaker implant, and they had no adverse events. So we really don't know what the issue is. We're talking to Medtronic to see what kind of data they have, but clearly this issue requires attention before it becomes a standard practice. Thank you. Any questions?
Do you have any idea of the frequency of complications in non-leadless pacemaker situations? It's a tissue issue.
Yeah. There was a comparison recently published between those who had AV node ablation and those who did not. And the two complications that really stood out that were unique and statistically significant for those who had simultaneous AV node ablation and leadless implant was cardiac perforation. They had more cardiac perforations and they had more pacing issues. So based on, and that involved 197 patients. So pretty robust data suggests there is a problem here. We just don't really understand it at this point. Sorry, I kept my mask on. Thank you.
Okay, next we have Dr. Judit Karacsonyi, who comes to us. She's an MD and PhD from the University of Szeged, Faculty of Medicine in Hungary. She did her fellowship, finished her fellowship in 2019 and has worked at the University of Szeged before coming here in the winter of 2020. She's got a prolific track record of publications and worked with Dr. Berlakis at UT Southwestern previously, and has written numerous textbook chapters and publications here during her time at MHIF. So we welcome her today to present her oral talk that's going to be at AHA on the use of mechanical circulatory support and CTO percutaneous interventions, insights from the PROGRESS-CTO registry.
Can you hear me? Is it good? Okay. So it's a pleasure to present here today at the Grand Rounds of MHIF. My topic is on the use of mechanical circulatory support in chronic total occlusion percutaneous coronary interventions from the PROGRESS-CTO registry. These are our co-authors. I don't have any disclosures. So the use of mechanical circulatory support in complex coronary intervention is a subject of ongoing investigation, but the role of MCS in CTO-PCI is not well studied. CTO-PCI is a complex procedure, and it is associated with higher risk of procedural complication rates. So the use of mechanical circulatory support could reduce the risk of transient ischemia and the patient's tolerance of transient ischemia during these procedures. So it could facilitate complete revascularization in these procedures. One of the limited data is on this topic is a paper from 2018. It showed that elective MCS was used in 4% of CTO-PCI, and it was used in high-risk patients and was associated with similar technical and procedural success rates, but higher risk of complications. Our goal in this study was to examine the frequency, the outcomes, and the predictors of MCS in CTO-PCI. So to reach our goal, we used the data from the PROGRESS-CTO registry, which is a prospective multi-center observational registry. We reviewed the data of 8,718 patients who were enrolled between 2012 and 2020 in 35 international centers. We plan to determine the frequency, the outcomes, and predictors of MCS, as well as compare baseline clinical angiographic characteristics and clinical outcomes between the patients who had MCS compared to those who where MCS was not used. This is the map of the PROGRESS-CTO registry. Currently, we have more than 9,000 procedures in 63 participating centers. Most of the sites are situated in the US, but we have more and more sites from abroad, from Europe, and from North Africa and Asia too. The details of the statistical analysis is listed on this slide. Categorical variables were expressed as percentages and were compared using Pearson chi-square test with the Fisher's exact test, and continuous variables were presented as mean and standard deviation, or median as interquartile ranges. And they were compared using students' t-test and the Wilcoxon rank sum test as appropriate. All of the analysis was performed in the GMP statistical program, and we two-sided p-value of less than 0.05 was considered to indicate statistical significance. So we used the data for this analysis from 8,718 patients. We had to exclude those patients which had no information on MCS use. So we were left with 7,171 CTO PCIs, and then we divided them to two groups where MCS was used compared to those two where MCS was not used. In 310 cases, so 4.32% of the population was used where MCS was used. So now let's have a look at the results. The baseline clinical characteristics are presented in this table. We can see that the patients where MCS was used were significantly older. They were more likely to have different comorbidities such as diabetes mellitus, dyslipidemia. They had lower ejection fractions, and they were more likely to have congestive heart failure and the prior myocardial infarction. Also, they were more likely to have prior CABG surgery, prior cerebrovascular disease. Regarding the presentation of these patients, they were more likely to present with unstable angina or non-STEMI or STEMI compared to those patients where MCS was not used. Now let's have a look at the angiographic characteristics. The most common target vessel was the right coronary artery in both groups, but the lesions where the MCS was used were more complex, so they had higher JCTO score and also higher PROGRESS-CTO score compared to those where MCS was not used. These patients where the MCS was used were also more likely to have moderate to severe calcification, moderate to severe proximal vessel tortuosity, proximal cap ambiguity. So these were angiographically more complex lesions. They were also longer and they required more stents. Regarding the successful crossing strategy in both groups, it was most common, the antegrade wiring was the most common successful crossing strategy. But when we have a look at the other successful crossing strategy, we can see that the retrograde approach was more common in the MCS use group. When we have a closer look at only the retrograde crossing strategy, we can see that it was used in 52% of the patients compared to 30% of the patients where MCS was not used. On this table, we can see the procedural outcomes of the patients. We can see that the technical success was significantly lower in the MCS use group, as well as procedural success. And there was a higher peri-procedural major adverse cardiac events rate. And the difference was more than tenfold between the two groups. And the procedures where MCS was used also required longer procedure time, longer fluoroscopy time, and more air camera radiation dose. At this slide, we represent the difference between the procedural outcomes. We can see that the technical success was lower in the MCS group, and also the procedural success was lower. And there was a big difference between the major cardiac adverse event rates between the two groups, and it was higher in the MCS use group. This is the detailed table of the different kind of major adverse cardiac events and other type of complications. We can see that almost all components of MACE were more likely to occur in the MCS use group, except the emergency CABG surgery. And also other type of complications such as perforation and vascular access site complications were more common in the MCS use group. And this graph represents the complications. We can see the big difference in the overall MACE rate. And also there is a big difference in the perforation rate. More than double amount of perforations occurred in the MCS use group. Regarding the different types of mechanical circulatory support, most commonly the mechanical circulatory support was used prophylactically we defined this as the MCS used at the beginning of the procedure, and urgent was defined when they started to use the MCS after the procedure started. That represented 21% of the cases. The most common type of MCS was the Impella CP, followed by the intra-aortic balloon pump, tandem heart, and the Impella 2.5. So to conclude, in a contemporary multicenter registry, mechanical circulatory support was used in 4.3% of CTO PCIs, and urgent MCS was associated with lower technical and procedural success and higher major complication rates. And further investigation is required to see if elective use of MCS can improve outcomes in patients with increased comorbidities and higher lesion complexity. Thank you for your attention.
Did you try did you try to adjust for comorbidities? Did you do any propensity matching between the two groups?
Thank you for the question. That's an excellent point. We haven't done the propensity matching. We did separate analysis on prophylactic use of MCS and on urgent use of MCS. We haven't looked at that, but that's a great idea. We will do that for sure.
Just one online question comes from Dr. Chavez, who asks, do you know if the mechanical circulatory support in this study, were those done as bailout or planned pre-procedure or pre-planned procedure?
So we defined prophylactic use as the planned use. So when the operators decided before the procedure started and they implanted before they started the PCI, and then the urgent use of MCS was defined as a bailout. So that was when they started to use it after the procedure, probably due to some complications or ischemia occurring during the procedure. Thank you. Yes.
The MACE rates compare in the, because all of the people in MCS were higher risk for the CTO, right? And more comorbidities. How did the MACE rates compare in patients who would have those higher risk scores that weren't getting prophylactic MCS? Was it similar? Meaning, was it the MCS that led to the higher MACE rate scores, or was it just that they were more complex, higher risk patients?
That's a great question. So when we did the analysis on the prophylactic group, those patients were also more complex. So they had higher comorbidities, higher more complex angiographic characteristics. So overall, those patients were more complex. So we can't really answer that question if it's like because of the,
if they were higher risk.
yes, if they're higher risk or it's because of the, thank you. Yes.
When you use prophylactic support of any kind, I assume your ACTs run higher because you're giving more anticoagulation. Does that reflect on the tamponade risk, perforation risk, or anything to do with the bleeding? Because that was very differentiated between the two groups.
Yes, thank you for the question. So indeed, the vascular access complications were higher and bleeding was also more common in the MCS use. There are no strict guidelines where you should use the prophylactic MCS based on the AHA guidelines. It's a to be level of evidence, a recommendation to use prophylactic MCS, but it's not clearly defined. This was one of the goals of our study to determine when do we use it. Another part of in our analysis, we try to find the different characteristics which are associated with urgent use of MCS to identify those patients who needed MCS as a bailout, because in that group, the difference was even higher. So in those patients, then we could potentially use the MCS upfront, and then we would get better results.
So again, I agree with you, but I think to answer the question is, we run a high ACT in general for CTOs. So I don't think it's the ACT, it's the big femoral seat. It's 15 French or 14 French for Impella. I mean, I think this is probably why we get the vascular complication. It's not the ACT because we do run 300 plus or 350 plus for CTOs.
I mean, pericardial effusion, say if you have a, if you're going to do re-entry, if your ACT is higher, obviously you have a risk. This may be a very basic question from a surgeon, but I think you can answer it. When you say MACE rates and especially ischemia rates, is there a ischemia rate in the territory you are intervening or territory you are accessing? I mean, if you're opening a right CTO and you're going through the septor when the guide was there for a long time, is there a difference in those rates at all?
Well,
that's hard to define, but we count both areas as, potential ischemic complication rates, when we're doing this. And you have to be very, very, obviously very vigilant that you're not making other areas ischemic. I mean, to your point, I think.
But about half the complications are the donor vessel.
Yeah.
You mess up the donor vessel or the septal. So you're right. It's not just the CTO territory, it's the donor vessel if you go retrograde vessel.
So years ago, this time of year, I remember sitting around the table with the University of Minnesota Fellowship Selection Group, and we had a fantastic husband-wife combination from Argentina. They were training in University of Miami, and we're like, could we really attract these guys to come to Minnesota? So obviously we did, and Santiago did his cardiology with us and interventional cardiology, worked at the VA after that for a few years before joining us. He's an expert in structural, valvular, and congenital heart disease, a leader in the COVID STEMI registry. And this morning, he's going to speak to us about HALT, the long-term clinical impact after TAVR.
Can you hear me okay? Hard time convincing them that I was serious about moving from Miami to Minnesota, but I did. Anyway. All right, so I will be discussing this is our work over the last several years on the impact of HALT. This was presented at TCT recently. These are my disclosures. In 2015, Rush McCart and the group at Cedars-Sinai first published from the Portico IDE study and two prospective registries, Resolve and Severy, on the incidence and possible association with adverse outcomes on an imaging finding, which they define as HALT, hypoattenuating leaflet thickening, with or without restricted motion. They also noted that treatment with anticoagulation, in particular with warfarin, was both protective and therapeutic in patients who had the disease and follow-up CTAs. Against that background, we adopted a routine screening program and treatment with at least 3 of 6 months of anticoagulation of all HALT patients that underwent CT at 30 days. The decision to initiate treatment was left at the discretion of the treating physician, but in general, we recommended vitamin K antagonists, irrespective of the severity of HALT around. For the purpose of the study, we used Philippe Blanqui's classification to define HALT, which you can see here is typically defined as increased leaflet thickness with typical meniscal appearance in at least 2 different multiplanar projections. Both the severity of HALT and round were graded using a 5-grade system, with high grades indicating more severe cases. The primary outcome of the study was overall survival at the median follow-up of approximately 2.5 years. We used Cox regression analysis to identify variables that were independently associated with the primary outcome. We also collected data on echocardiographic, ischemic, and bleeding outcomes for both HALT positive and HALT negative patients. And for this analysis, we included patients from 2015, which was the time we started the program, to 2019. Overall, 856 patients underwent commercial TAVR during the study period, and of those patients, 75% of 638 underwent a CT at 30 days. The most common reason for exclusion was the presence of chronic kidney disease, and those patients did not undergo a CT. The incidence of HALT, which is in line with previous studies, was 12% at 30 days. With regards to baseline characteristics, HALT positive patients were on average a little bit older, but not significantly so, about 1.5 years older than HALT negative patients. They have similar burden of comorbidities, similar STS scores, and as previously reported, they were more likely to be on anticoagulants pre-TAVR, both NOACs and vitamin K antagonists. With regards to the echo parameters, HALT positive patients had somewhat lower gradients and lower peak aortic velocities, but similar ejection fractions, left ventricular dimensions, and prevalence of polyvalvular disease. No difference in CT characteristics, same annular area, same calcium score. The overwhelming majority of these procedures were done using transfemoral access, and 2/3 of them were done with balloon expandable valves. As expected, and according to our protocol, the use of warfarin increased significantly at 30 days in HALT positive patients, peaking at 85% at 3 months and staying over 50% on 1 year. In contrast, for HALT negative patients, the use of warfarin was about a quarter, which is very similar to the incidence of atrial fibrillation in that population. Because these were treated patients with warfarin, we observed no difference with regards to echocardiographic gradients, both at 1 month and at 1 year. HALT severity, the majority of these cases were 1 or 2 leaflets. And we noted a tendency towards more single leaflet involvement with SAPIEN, more dual leaflet involvement with Evolut. But the severe cases where the 3 leaflets are involved were similar between the 2 commercially available platforms and affected less than 10% of patients. Analysis at the leaflet level, and I'm thankful to Michos, he will expand on the next presentation on this, shows that the less than a quarter of cases were grade 3 or 4, which are the most severe cases. And no difference was observed here between SAPIEN and Evolut. Similarly, analysis of restricted motion showed that the majority of these cases were mild, with less than 20% of them being grade 3 or 4. Bleeding events, we were interested in safety outcomes. So this is landmarked at the time of CT at 30 days. We observed no difference between HALT positive and HALT negative patients with regards to bleeding as defined by BARC2 criteria. The primary outcome of the study, which is overall survival, was significantly reduced in HALT positive patients with a p-value of 0.0096. This is after a median follow-up of 2.2 years. The absolute incidence of mortality at the end of the follow-up period was 30% for HALT positive patients, 20% for HALT negative patients. So 10-point absolute difference with no difference in ischemic outcomes or stroke. In a Cox proportional hazard analysis, HALT positivity was independently associated with long-term mortality with a hazard ratio of 1.83 and a confidence interval that goes from 1.13 to 2.97. Other predictors were age, male gender, and transfemoral access, which was protected. Of the 79 patients who were HALT positive at 30 days, we had follow-up CTs on 64 or 81 of the original cohort. Complete resolution of HALT was noted in the majority of patients. 82% had complete resolution of HALT. About 20% did not have complete resolution of HALT. We noticed that there was a difference between the 2 platforms. 10% of SAPIENs had persistent HALT and 38% of Evolutes had persistent HALT at 90 days. We need to understand what that means, as the majority of these cases were mild. They were not severe. The study has to be interpreted in light of the following limitations. It's an observational study, and therefore our findings are hypothesis generating rather than confirmatory. The role of routine screening and treatment is controversial. As you know, the natural history studies, which were not available when we designed this, show that HALT resolves in approximately 50% of patients within a year without treatment. But it also can spontaneously occur between day 30 and 1 year in about 20% of patients, so that the overall incidence at 1 year tends to be higher than what it is at 30 days. We only have 1 CT, and we made decisions based on that for the majority of patients. This is obviously a single treatment arm without a control group of HALT positive patients that were not treated. And we don't have an independent events committee, so the generalizability for findings is limited. Nonetheless, screening is feasible in most commercial TAVR cases, with 74% of patients receiving a CT at 30 days. HALT is present in 12% of patients, which is in line with previous studies. And treatment with vitamin K antagonists is highly effective with complete resolution in 82% of patients. Having said that, HALT positivity was associated with increased risk of mortality over long-term follow-up. The value of routine screening, therefore, and treatment of asymptomatic patients with normal gradients remains unproven and certainly cannot be recommended at this point. And we need further studies to better understand what this finding really means. Thank you very much for your attention. Yes, thank you.
That's a great study, Santiago. So when you find it, is there a general consensus as to how long we should treat? Will it come back if you stop the anticoagulation? And is there any role for DOAC?
Yeah, so the first question is, the program was launched in 2015 and the consensus was 3 to 6 months, depending on the risk profile of the patient. We bring the patients back, and as I show you, the majority come back for a follow-up CT. If there is complete resolution of HALT, as happens in 80% of patients, we stop the anticoagulation, unless there is another reason to be an anticoagulation. If there is persistent HALT, it's really dealer's choice as to what we do. And I've been moving towards looking at the severity of HALT. If it's, yes, just one leaflet, the gradients are okay, we may decide to just do aspirin alone. But we don't have a standardized protocol for all those patients. And it's actually a complex decision because it's the risk profile of the patient, HALT severity. We have uncertainty as to what this really means. And so this is just to give you perspective, the low risk studies, they all mandated by the FDA to obtain CTs and to watch these patients for a year. And both the low risk partner study and the low risk Evolute study showed no safety signals in HALT positive patients. But those are low risk patients. If you put them together, all the HALT positive cases, we have more cases than both of them combined. And our follow-up extends beyond 2 years. They only look at 1 year follow-up. So this is a quite powerful data set.
How do you know that HALT would not have gone away or would have gone away without treatment?
We know that from the low risk trials where the DCTs are 30 days and 1 year. We can't tell which patients are going to behave that way, but about 50% of HALT positive patients at 30 days. If you don't treat them, just watch them. At 1 year, the CT finding will be completely gone. And then 20% of the large pool of people that don't have HALT at 30 days may develop HALT. So that when you look at the incidence at 30 days is 12%, the incidence at 1 year is about 30%. And as much being it is like this, it's the same for surgical valves. Yeah.
But if you stop the anticoagulation, you know it's not going to come back.
We don't.
Has anybody looked at DOACs?
Yes. Thank you for asking. So two approaches have been taken here. One is use CT to decide who gets treated. And that's what we're doing. But there were NOAC trials after the Rush-Macquart data, looking at treating all TAVR patients because it's a huge market. And this is what the data shows for Galileo, which was stopped prematurely. Rivaroxaban, 10 milligrams a day after TAVR, highly effective in treating HALT, preventing HALT. And this is very similar to what we're seeing here. You have the surrogate marker, which goes in one direction, and the outcome go in the opposite direction. So very effective in treating HALT, yet there was increased risk of mortality in people treated with rivaroxaban. We don't fully understand why. They also had, it was not purely due to bleeding, actually, it was due to thromboembolic events. So we really need to understand this and get this right because we're putting these valves in a lot of patients. So I think it's important. I do think it's a pharmacological problem. And Mijo will also provide some data as to what are the reasons why people develop HALT.
But it seemed from the recent valve guidelines that if you have a patient with another indication that the DOACs are acceptable,
Correct.
right?
Correct. So
Would you choose something other than?
yeah. So for the guidelines are based on atrial fibrillation indications, et cetera. This is a different approach. They use half dose rivaroxaban, 10 milligrams. They didn't use full dose for what we use for atrial fibrillation. So yes, if you have an indication other than HALT in a patient, and the patient was taking a NOAC before the TAVR, it's perfectly reasonable to do that post-TAVR. And we do that clinically too. We don't change it to warfarin. But to initiate a NOAC just for the purpose of treating HALT, I think it remains unproven right now. Yes.
Questions. One, do you see HALT on non-expandable valves, i.e. surgical valves? And is the morbidity and mortality issues present, or has anybody looked? And then two, if you develop HALT a year out, is the mortality association with HALT the same as it was at the 30-day CT mark?
Yeah, so this is a summary of all the low-risk trials with HALT. And they both had surgical and transcatheter patients. And you can see the number of people we hold in each individual study is small, 35 for the partner study, 31 for the Evolute study. The middle one is the Washington Hospital Center, but none of them really saw a safety signal up to 1 year. And there was high gradients in the partner study, and they both had a surgical arm. And that's the best data that we have for surgical valves. And I guess that was the purpose of this analysis mandated by the FDA. Was seen on surgical valves. We don't have a safety signal associated with it quite yet, but I think there is a planned 5-year follow-up for those patients as well. Vinny?
I think let just slightly clarify this as well, because although statistically, et cetera, which, show surgical valves, it's always a defense of a technology, right? You have a problem, then you show that, oh, some surgical valves also have that. Nobody has understood that yet. And this is one thing we really need to define when we are offering patients TAVR as well now. Should we have the same protocol to check them? The second thing is, I think one month CT is too soon from the data you presented. I think we should push this back to say 6 months CT, because maybe 1 year. So this is where it becomes really meaningful. Let's not forget that biological valves were designed so that patients don't want anticoagulation. And we are really going away from that principle now. So if we're putting 35% of patients on anticoagulation, might as well put a mechanical valve and get it done with. So I think there are good old Saint here. No, but what I mean is we need to.
We can't do that from the groin yet.
I think what I'm saying is that let's not forget why patients choose biological. And I think this data is really good because this shows that HALT comes and goes. Funny enough, nobody has yet characterized what is this. Means what I mean is if there's a HALT, nobody has actually operated on this patient and shown there is a thrombus. This hasn't happened yet. And patients in which it comes back and forth, these are the patients who need lifetime anticoagulation. That's very clear as well. It's still muddied water. We still need to understand it.
Well, we're not going to sort that out today, but I tell you this, Mijo will present data as to why this happens, which I think is very, very enlightening. So Mijo, I will let Dr. Harris introduce you.
And has anybody looked at like a murmur predictive of HALT?
That requires a stethoscope.
Don't go there.
All right, so we want to allow Mijo Fukui time to present. She is an international research scholar in the Imaging Research Center and Core Lab. She completed her cardiology fellowship and PhD in Japan. She worked with Dr. Cavalcante in University of Pittsburgh and is now been working with us and is going to present her work on HALT.
Can you hear me now? Thank you for this opportunity to present our study about TAVR processes deformation and its relation to the HALT. So I presented this study at TCT conference just 3 years ago. So that's a slide. So, oh, that's great. I can zoom up. Sorry for, can I? Oh. So now you already know what HALT is and why HALT is important, thanks to Dr. Garcia's presentation. So while HALT therapy continues to grow, there have been concerns regarding the HALT occurrence, which may affect process valve function and durability, and also the clinical outcome. But its relation to the anatomical characteristics of processes after implantation remains unclear. So we comprehensively assess the structure of implanted sapien sleep valve using 30 days post-procedure CT in 352 patients who received the TAVR. And we found 3 important factors representing TAVR process deformation. The first one is processes deformation index, which represents a degree of the relative under expansion of mid-segment of sapiens 3 valve. A relatively larger deformation index represents more hourglass shape, while a relatively smaller deformation index represents more cylindrical orientation. The second factor is a symmetric leaflet expansion. As you can see here at the coaptation level, yellow dot line, which is evaluates the degree of the expansion of each process leaflet. Greater degree represent more asymmetric leaflet expansion. The third one is neosinus volume. As you can see here, as a red on the top left, which is the volume of the process leaflet within the frame. So, sorry for, I'm not used. So here's the example. In the case with HALT, you can see a relative under expansion of mid-segment of sapiens 3 on both of fluoroscopy immediately after the procedure and cardiac CT. You can also see the symmetric leaflet expansion like this. So now, let me show you our result. Overall, HALT occurred 21% of the entire cohort. Patients with HALT had higher prevalence of atrial fibrillation and use of the post-dilatation and anticoagulant therapy. But there was no difference in their baseline clinical, echo, CT, and TAVR procedure. So as you can see here, processes deformation index, asymmetric leaflet expansion, and neosinus volume was directly related with the HALT occurrence. Patients with HALT, which is orange, had more hourglass shape, as well as greater degree of asymmetric leaflet expansion and smaller neosinus volume. More hourglass shape was associated with smaller neosinus volume. And importantly, HALT, which is orange dot, more often occurred to more hourglass shape and greater degree of asymmetric leaflet expansion with smaller neosinus volume index. We also assessed the eccentricity, implant depth, canting, commission alignment, and elbow stroke volume index using post-procedure CT. Except for implant depth and stroke volume index, there was no difference between patient with and without HALT. Furthermore, in a multi-regression analysis, these all three factors representing TAVR process deformation remains associated with HALT occurrence, along with the use of anticoagulant therapy. So ladies and gentlemen, in conclusion, TAVR process deformation, frame deformation, asymmetric leaflet expansion, and smaller neosinus might explain HALT occurrence following balloon expandable TAVR. Our finding may have some implication for both valve design and deployment technique to improve clinical outcome with TAVR. Thank you for your attention.
I'll start with the question. Other part of this is, I think it would have been helpful if we had a baseline comparison of a surgical valve here, because or we may have it still, as far as the leaflets and everything goes, because technically speaking, we always believe that surgical valve with rigid frame, rigid base at least, remains pretty circular when we implant. Although in early days, valves such as Perimount 2700, which is still used, there is some degree of ellipticity in that, and that has been shown to be less durable. So it might, give you some baseline to compare as well. But are you surprised at these findings that more deformation leads to bigger problems?
So you're asking more deformation, why more deformation associated with the heart? So yeah, there are some previous study using a model. So they found using a model, so like a eccentricity or which these flame deformation could impact on the leaflet pinwheeling and sometimes leaflet bending, something like that. And also there is another study. They showed there is a flow stagnation on the bottom of the sinus here. So I'm thinking these deformation, especially this mid segment, could cause more like a tribulation or outer inflow. So that's a reason why these flame deformation could cause heart occurrence.
That's a very nice observation and comment, because we see sometimes even on the mitral side, when we do oversize quite a bit, that there is pinwheeling, the leaflets at the base, they don't completely open. And that in part might be causing some flow stagnation with computational fluid dynamics. They have shown that the washout is not complete. That might be the nidus where it begins and goes until tips. How we can predict that with the baseline CT is the question, right? That we need to obviously work on. We have the posing plan, so we can try to anticipate, at the given force, should we have gone with the higher balloon inflation or choosing a different prosthesis. We're still working on that.
Yes.
But in low-risk patients, this may be really important. So if you can predict this, then you can advise that a relative risk of fault. And then you choose to do the surgical output. And is there a difference between your outflow diameter specifically? Because we know that when the outflow is flared, so to speak, the gradients are less. That's why we flare it. In the mitral, we flare it so that it doesn't embolize. But obviously, it may affect closing mechanism. So have you looked at just the outflow flaring versus the waste? Let us indicator by itself.
Sorry.
So is I think, translating here, I think that might cause even more deformation index, because what she's measuring is, at the leaflet domain there, as you can see that hourglass shape, that's would be divided by the sum of the two. So when you flare, that is going to be a larger area relative to the middle portion. And so that would be even more so, but I don't think we have done that particular analysis.
We should look at that specifically, because the narrow diameter is at the MUT.
Yeah.
But at the top, the device, especially balloon expandable, always flares. So maybe that might be a really separate indicator.